So we are really fortunate to have you with us, and he has a clinic in India and abroad. So he's a true global, global icon, and he's very innovative. Lot of inventions, patents, Chawan keratoprosthesis, presbyopia, orthokeratology lenses. Very few people know that there are myokido and hyperkido lenses, light sensitive dilating artificial eyes, diamond and gold embedded cosmetic lenses. I mean, when I had heard first time, I thought, wow, you have now jewelry in contact lenses. Wonderful. I mean, your innovations are so out of the book. We were talking, and you were telling about, you make lab grown diamonds also. So that is so wonderful. And he right now has a clinic in Mumbai and California, and he continues to not only pioneer in optics and ocular prosthetics, but keeps on amazing us with all his new inventions and new. Is my voice clear? Acha.
Yeah, I can hear it properly.
Okay. So we will get on with the, with from the horse's mouth. Really great innovation, sir. And I'm pretty sure that there will be a lot of learning from you directly on orthokeratology and red light therapy, especially in myopia. Over to you, sir.
Thank you so much, Doctor. It's really a pleasure talking to you once again. Thank you so much for the opportunity to share my, little bit the knowledge about orthokeratology and myopia control. Let us see if I can share my presentation. I hope you can see my PPT. Doctor, are you there?
Yes, sir.
Yes, sir.
Okay, great. Okay. So I have, of course, no financial interest in particular talk. I'm just trying to go from the basic to little bit of, what you can say, takeaway points that you can start practicing maybe from Monday. So, as the term orthokeratology, most of you must have heard about dentistry. So they put some clips and put some wires and try to reshape the tooth. So similar concept here, where we put some specially designed reverse geometry RGP contact lenses and reshape the epithelium so that you can see, we can get a focusing on the retina or fovea to see clearly. So it's basically reverse geometry contact lenses. This is FDA approved in 1984 about. That time they used to provide the red and yellow, and now of course you have green and blue color contact lens. So how it works basically is basically pull and push technique. When that reverse geometry lenses are placed on the cornea, the 50 microns of epithelium gets reshaped because of the forces acting, and push. And wherever there is a pressure, the cells become little thinner, and when in the reverse zone, the cell gets swollen away, and that is how you get the effect of refractive error correction. So these are the terminologies. Get rid of this. So peripheral curves, alignment curve, fitting curve, base curve, you will need to know in case if you want to talk to the lab and discuss what you want to changes, do make any changes, or when you are designing your own orthokeratology lenses with the use of some RGP software or any other software. So basically, this is the base curve that corrects the major power. Say if the cornea is 44 diopters and if patient is 3 minus 3 diopters, myopia, the base curve will be 41 diopters. I'm just giving a rough idea. So it's like a stamping on the corner. This reverse geometry, reverse curve helps to get those forces correct and get the swelling done in that epithelial region and get the shape of the epithelium change. The alignment curve try to make the lens focused centered properly. It should not go up, down, right, left. And this is for the peer exchange, the edge. You don't need much of a different instruments than what you have in your practice right now. Vision testing, drum, fitting sets, slit lamp. What extra you need is a topographer because we are changing the shape of the cornea. So you should have the more information than keratometry. Keratometry gives you only two data points, right? K1, K2. Here you are changing the whole cornea, so you should know what is happening and what was the base and what you changed because of your reverse geometry contact lenses. So you need a topographer which gives more than 10,000 data points. There are a variety of topographers available in the market. You can use Pentacam, you can use any other thing. The Medmont, the central one, is the gold standard, especially for orthokeratology, because they have some extra features that but any topographer will do the trick. So you have to capture the image properly to get a perfect uh, topography information. Most of the time, when you take a topography image, you ask patient to look in the center dot, that there is a red dot, but there you are getting a visual axis. And if you ask patient to look a little bit off, then you get a geometrical capture. You are interested in geometrical capture actually to get a perfect fitting orthocal lens. But even if you get a visual axis, that's fine. You can evaluate fluorescein, but that is not the main way of evaluating this reverse geometry orthocal lenses because the fluorescein will keep on changing every minute and you will actually not get a correct understanding. But yes, you will get something like, there is a central touch, there is a pulling, then there is a touch. Okay, this is what you're going to get with the maps that you get are basically helpful in understanding what is happening on the cornea. So subtractive map is usually used, axial subtractive map, to understand the effect of the uh, treatment. So the first is this virgin cornea, and then next, when you apply these orthocal lenses overnight for 8 hours when child wears it, and next morning when you see, you compare with the first uh, image, and this is what you get is a subtractive map. If you get something like this, it is called bullseye pattern, and this is what you are expecting, and this is what the best tangential subtractive map is used especially for myopia. What you need is a treatment zone less than 5.5 millimeter, 6 millimeter. That means that plus power should be lying in the pupillary zone at the periphery. That will give that hyperopic defocus and myopic defocus and send the signal to the brain to control or stop the axial elongation. And if you're doing this orthokeratology for adult, for just myopia correction, then you don't want this in the central zone. It should be well away, more than 6, 7 millimeters away. Otherwise, the patient will experience halos and distortion when they are trying. So these are the different maps that represents the fitting of the lenses under the close eye situation. Because when you see the patient and do the topography, you will know what happened. The lens was there on the eye for 8 hours because you cannot check the fitting when under the closed eyelid situations. Another thing is apical astigmatism. If the astigmatism is less than 1/3 of a spherical power and it is in the central zone, then you can get away with a regular spheric orthoke lens. But if you have a limbal to limbal astigmatism, what you need is a toric orthokeratology. When the orthokeratology came into practice in about 1984, I started. About that time, it got FDA approval. Yes. So that time only spherical ortho K was available. About last 5 years, now toric ortho K is also available because most of the children nowadays has a high astigmatism. We don't know why, but that is the fact. So you need a special design to address that. Lymphatic astigmatism can be corrected with a regular, simple aspheric ortho lens, whereas for lymphatic, first basic topography capture is most important before you put any lens on the eye, because the moment you put a trial lens or any orthocal lens just to show the patient how it looks and all, how you feel and all, you're distorting the epithelium and you are not going to get the virgin base map. So make sure that you take a topography first and then you start putting any trial lenses if you want. In my opinion, you don't need a trial set for orthokeratology. What you need is a perfect topography map, and the lab will make the lenses, or even you can make the lenses, design the lenses. So axial map, tangential map, evaluation, refractive map, wavefront map, and height map. These are the maps that you will come across when you are fitting the orthocal lenses. As I said, spherical or toric lenses. So the difference between two uh, curvatures or the zones is less than about 23 microns. You can get away with the spherical lenses. But if it is more than 45 microns, this curve and this curve, so the axis is different, and then you get a more than 45 microns, and then you will get a bubble, or in ortho K terms, what you call is a leakage. When you put a fluorescein, you will never get that ring to hold that suction properly. So this is what I was talking about. This is a leak. So this lens will never give a full correction, and patient will keep on complaining. What you need is something like this. So 360-degree seal off, we call it. This is a astigmatic toric orthocal lens. So subtractive map is used. Patient was sleeping, so you don't want that situation. The lens is not pushing from central zone. It now height issues, and you have to address. So you have to address that this thing with the lab. You once you share the topography map, they know what is happening and they will do the correction and send you another lens. So smiley map, as I was saying, the lens was riding high, so it is little bit loose alignment zone, and it needs to be corrected properly. Brownie face, same thing. It is little tight lens, and lens is riding little low. So you have to compare two maps, that is the first map and the follow-up map, and then understand what is happening. Bullseye map. Now, of course, you have been undergoing this course for myopia control, so I don't have to stress again. But just to complete my talk, I put this slide. So, epidemic of myopia is now well known around the world by Brian Holden's one of the papers, Brian Holden Vision Institute's paper. They predicted that the whole world's 50% of the population will become myopic by 2050. So, it is really a health challenge, and everybody being in the eye care field should be sensitive about that and try to control the myopia less than -3. Otherwise, you're going to get cataract, glaucoma, diabetic, retinal detachment, retinopathy, and other stuff. So these are different causes of myopia, as everybody knows. Parental, air, eating, environmental factors, our lifestyle, sugar intake, dietary influences, insufficient vitamin D. So many factors are there, and that you have to address. And of course, coming to the most optical stimulus part, which is the main cause of or major cause of myopia is a lumens, that is the intensity of the light. It's a chromatic signal, electromagnetic signal. Optical defocus theory works to control the myopia because optical defocus is the cause for myopia progression. When you do a close work for a longer time, you're creating a hyperopic defocus at the peripheral retina, and that stimulates retina to keep on enlarging, or the eyeball axial into enlarging. So there is a error in metropization leading to myopia. So what you do is simple. You put a glass, right? You correct with the simple glass. But that is what actually pushes the myopia in progression. Because the moment you put the corrective glasses, what happens is that image shell is pushed behind because you're trying to focus the rays on the fovea, but peripheral defocus happens to hyperopic condition, and the signal is sent to the brain that, hey, it is now time to grow, to reach to that level. So hyperopic defocus is the culprit for myopia progression. So what to do to bring this to myopic defocus? You create something which will give a dual focus, something like bifocal glasses, 360-degree bifocal or multifocal soft contact lenses, or orthokeratology, because orthokeratology will give a 360-degree myopic defocus like this. So central portion will give the correction at the fovea, and this ring which gives the plus power and gives the myopic defocus, sending signal to brain, hey, stop, no need to grow further. So there are so many glasses available in the market. I also try to put in my little bit of contribution as simple myopic mobile specs. I call it. Central there is nothing, and periphery there is a 360-degree base in prism with plus high power, creating a myopic defocus. Of course, cosmetically it doesn't look good, but it works. Earl Smith is the scientist who has done a lot of research on animal eyes, and he proven that defocus works. And he's shown this different chicken eyes and other eyes, monkey eyes, and all, where it is shaped in a different way, or in growth happened in different direction. Bright light is important, as you know, because that will give a more focused light. What you are trying to control is not the number, but you are trying to control the actual length. And you have to measure this before you start to understand what is happening. As I said, there are many ways to do it. Multifocal, that is a bifocal, or progressive addition lenses, multifocal soft contact lenses, where center is distance and periphery is near power, and orthokeratology. This is what we are talking about today. This is the USA, not in India yet, but eventually it will come in India as well. Some papers have, studied or listened where they have used a regular bifocal contact lenses which are available in India. That also works, thinking that it causes distortion on the peripheral retina and gives that myopia control effect. But this is the real lens which is available in the market. Or if you can make a lens with the central distance power and peripheral near power, there are a lot of companies in the US who customize soft contact lenses as you wish, and you can prescribe it to your patients. I'll be happy to help anyone if anybody is interested. So to control myopia, it is not only orthokeratology. There are so many other modalities, and you have to combine all those modalities to address to that particular patient, looking at his myopia, whether high myopia, low myopia, progressive myopia, parental myopia, his lifestyle. So many factors needs to be considered and applied, and then decide what lenses you want to prescribe or what modality you want to do it. Dr. Jethani, myself, and Dr. Quresh Maskati has come up with this myopia risk calculator. So you can give these points. You can read, ask questions, and put that points and add all the total. If it is less than 7, the child is safe. If it is between 7 to 12, you have to start actively doing some myopia control measures. If the points added is more than 12, then you have to go aggressively and try and apply dual therapy or whatever best possible way you think is useful, and try to control the myopia. So start early, consider parental myopia. Time outdoor is important, 2.5 hours minimum outdoor sunlight, daylight activity. close work time should be limited or try to make it less. Try to keep the reading writing distance little more than 16 inches. You can start with low dose atropine. Now fortunately, we have 0.01 as well as 0.05% atropine. So if the risk factor is more for myopia progression, you can start with a higher dose. I think Dr. Jetani is the correct person to guide you on that. Lighting condition, as I said, more and more light lumens should be more, especially doing the close work at the home or indoors. Uh, Now, light therapy is becoming more and more interesting because it is showing good results. So, I'll be talking in the next half of this talk on red light therapy. Of course, food is also a factor because whatever you eat, you become. So, exact link is not known, but yes, it is definitely there. And you can start with multifocal lenses of specialty, spectacle, which are available by multinationals also in India. So try to create a peripheral defocus with orthokeratology and try to give a smaller optical zone so that that plus power remains in the pupillary zone and causes that myopic defocus, sending signal to brain to stop the actual length elongation. You can start with atropine combined with the optical defocus to have a long lasting effects. I also came with my defocus glasses, where the multinational glasses which are available in India are do not give more than -9 power or -7 power, whereas I come up with my glasses where there are plus defocus design here, a very strong design, and I can give up to -20 diopters and 4.5 cylinder power so that you can take care of the high myopia. These are the SLR glasses with circular dots. They claim about 62% myopia correction. Hoya MyoSmart, which is available in India, has a honeycomb design. DIMS technology. It is all different name. Basically, it is causing a defocus to the peripheral retina. They are claiming about 60% myopia control. And Zeiss also has their corrective lenses. This is Myopido, which is my lens. So try and give any type of lens that you think is good for your patient, because even if you try to control 50% of myopia, you are really doing a good job. Controlling the bad effects of eye myopia, which is early cataract, glaucoma, retinal detachment, retinal other issues. So low dose atropine also can be combined with the optical defocus, and you get a better result because atrophy is supposed to be stopped after 2 years, but recently it is said that you don't have to stop every 2 years because atom study was only for 2 years. Everybody thought that you have to stop after 2 years. But nowadays, people are continuing for 4 years and 5 years, though we still don't know the long-term effect of atropine. I would like to stress on this particular paper where they have, shown only atropine compared to, say, control. So control eye growth was 0.41 in 1 year, 0.1% controlled by 0.36, 0.025 by 0.29, and 0.05 by 0.2. So what this means is more and more higher strength of atropine gives a more and more good control. So this is a control eye and compared with the ortho K. So with ortho K, you got 0.2 microns of actual length elongation, whereas 0.037 in 1 year. So ortho K works effectively equal to 0.05. But if you use only 0.01% atropine, because you don't want to put high dosage, and ortho K, you get 0.09%. That means the myopia almost halts down. So you can have a dual therapy, that optical defocus with ortho K and low dose atropine, and you get a perfect myopia control. So to order orthokeratology, what you need is just a refraction, fully corrected refraction, K1, K2 done with autoref, HVID, that is horizontal visible iris diameter, or VVID, white to white, and topography map. If you give this information, most of the labs will be able to make the lenses for you. Care and maintenance is most important in orthokeratology because the lenses are worn during the night and under the sleeping condition, closed eye situation. And if the lenses are not sterile, then there is a chance of corneal infection, which is the major cause people are worried about or afraid of wearing orthocal lenses. But believe me, it's absolutely safe. I have been practicing orthocal since 84 and I never had a single incident because I insist my patient to use hydrogen peroxide system when they store the lenses during the day. If they are not going to comply, I'm not going to give the lenses. Otherwise, because the blame is going to come to you. So make sure that hydrogen peroxide is used for storage of the contact lenses. The RGP contact lens cleaner or soft contact lens cleaners are not going to give you that protection. Believe me. So hydrogen peroxide system will definitely make your life easy, and there will be no. This is a gold standard for any RGP or scleral lens or orthocal lenses. Especially for orthokeratology, this is most important. I know there is limitation or scarcity of this clear care. Previously, there was AOSEP by Alcon. Now this clear care is available, but it is not easily available in India. So in fact, I have not added my slide here, but I have come up with the case with a special catalyst. You can take any hydrogen peroxide available in the market, and that case will neutralize the hydrogen peroxide. Or we have special hydrogen peroxide made available also. So follow up next day, you take the topography map and compare. If it is a bullseye map, then ask patient to continue with the lenses. After 1 week, you again call in the evening. Next day morning, you have to call patient and do the correct topography. Next week, evening you call so that you know the holding time. The patient should be able to enjoy the vision, clear vision throughout the day, morning till night. So especially in the evening, you take the topography and you understand how much is the holding time. Then after 1 month and then every 6 months, you have to measure the vision. If see when you do the diffraction, just a general refraction, okay, if you try to do autoref, you will get a very different powers. What happens is the orthocal lens has a plus 0.75 or plus 1.25 overcorrection. What does that mean? In the morning, the patient is overcorrected by 0.75 or plus 1.75, overcorrected by 1.25. By afternoon, his perfect power is corrected. By evening, it is undercorrected. But the child doesn't know that difference, or even adult patient doesn't know that difference, and they don't complain unless you make a point and tell them. So don't tell. This is, as a practitioner, you should know. So when you get a different power, when you see it's it is overcorrected or undercorrected, don't worry about it. So topography, of course, will guide you in fitting the lenses properly. These are the companies in USA which makes the orthokeratology lenses. There was one funny incident. One patient came to me, and his doctor from Vijayawada told him, "Oh no, the lenses are made in China." Fortunately or unfortunately, Chinese do not have this technology yet, though they have the highest number of myopia because Americans are guiding their secrets. Of course, recently this Euclid company was purchased by a Chinese company, but they are making it in USA following all the FDA guidelines, and they cannot make these lenses in China yet. So these are the different companies. In India, Preeti Mestri is offering, she is a distributor for contact OK lenses. And there may be another companies, I don't know, but I trust her. She is my fellow. The lenses are available in India. And if there is anything odd or more than -9 power, then I'll be happy to help you with my contacts in the US. As Dr. Jetani explained you, I have a practice in US as well, and I can get the lenses from my practice name. The lenses, usually orthocal lenses are not given to anyone unless you have undergone that examination and process, and you know exactly what you're doing, because you are altering the shape of the cornea. So it's very effective and it is reversible. So you can stop it if something goes wrong and you can again start over. Cosmetically pleasing, patient confidence improves, personality improves, and it's really amazing. Except the cost. Cost is a little higher, but as more and more practitioners starts practicing and more number comes in, the cost may come down. So these are some of my references. I'll immediately go into the red light therapy. And then we'll have a question answer session if time is permitted. So the red light therapy is called by different names: low light